All right, thank you very much. I'm going to be using my notes here because I just want to make sure I don't miss anything important. Man, that's a nice picture of me, young me. I'm going to keep that picture until I'm 80, so that's going to be it. So just before we really get started, this is more of a review. I live in probably the most prohibitive state for cannabis. Tennessee will be the very last state to legalize cannabis. Even after it's legalized federally, Tennessee has built into a law that they will wait 2 years before they will do it after that. It's crazy. I mean, it's like reefer madness in Tennessee. And I quickly looked at North Carolina, and North Carolina is right behind that. So how many of you guys are in states that have legalized cannabis programs? So because we're in the SMA, I guess that means the majority of us are in prohibition states. That doesn't mean that your patients are not utilizing cannabis quite a bit. So as physicians, we really do need to know how it's being used, how it's best to be used, or what are the risks associated with it. So we're going to kind of go through all of this today. So Dr. Meshulam out of Israel coined the term entourage effect. It's beginning to mean a lot of different things over the years, but basically cannabis is a complex plant that has multiple effects, and multiple components to the plant contribute to this entourage effect. We in Western medicine typically try to use monomolecular structures in order to control physiologic responses, but cannabis is a whole plant. Now, in most countries, cannabis is part of kind of a generalized approach towards medicine. Okay, I mean, it was up until 1930 or 1940, one of the most prescribed medicines in this country until it was prohibited. Okay, so it's a very important plant that's actually ubiquitous throughout any temperate nation, and it's grown on every continent, and it's been around since the beginning of time. So as a pain doctor, I went through the good and bad days of pain. So I was early on when we went through the period where we started liberalizing opiates because we were under the impression that the world had been undertreated with opiates, and we all know the unfortunate consequences of that. We can say without question, in the history of humankind, no one has ever died of an overdose of cannabis. It's physiologically impossible to kill a primate with cannabis. They've attempted to do so with rhesus monkeys, and the monkeys just standing in the corner with their heads down and just want to die, but they can't. Okay, so it's a safe alternative to some of the things we're using now. And I'll just kind of go, next slide. So we're going to kind of go over the basic mechanisms. We're going to understand what these minor cannabinoids are, how they're used in therapeutic and medical cannabis, and understand something called terpenes. Terpenes are very important with regards to cannabis. And I do not have any significant cannabis industry affiliations. And I use the word significant. I have a small dispensary, and I invest in a couple places, but I wish I could control the industry. No, I have no significant cannabis industry affiliations. This is primarily just to educate physicians. These are my personal opinions. As you saw, I worked for the VA. Obviously, as a federal government, it's legally prohibited to recommend cannabis. So this is just my personal opinions, and that's basically it. So, elephant in the room. The three main reasons a person will show up to a cannabis dispensary is going to be pain, anxiety, and sleep. When cannabis was first legalized in a lot of the United States, there was a big push saying that cannabis was opiate sparing. Then they looked at it and they said, maybe not, maybe not. Well, cannabis has been legal in Canada for over 6 years now. And they did a large prospective study of over 1,500 patients who were chronic pain patients of varying degrees. They had basically they were taking the equivalent of 132 milliequivalents a day of opiates, and after 6 months, because of recreational cannabis, physicians didn't do anything. They just followed these patients for 6 months prospectively. They dropped their medical equivalents, the equivalent opiates, from 132 to 32. Okay, so cannabis is safe, and it is an opiate sparer. These people were not told to stop their opiates. They just stopped their opiates because cannabis allowed them to decrease their opiates from 132 to 32. Okay, so Canada is just like the United States. In fact, Canada's number 2 in opiates use. Behind the United States, we're always number 1. So the take-home point from this, if anybody wants to go, cannabis is opiate sparing and safe. So this is a close-up look at one of the most beautiful plants in the world. Basically, when everyone thinks of cannabis as the little 5 leaves and, the green leaves and everything like that, but all the magic in cannabis is in the buds. And those little silver crystals and little red spicules and things, those are little generators of major cannabinoids, terpenes, and flavonoids. That's an electron microscope looking at these at the cannabis vesicles. You can imagine that this is just little generators of chemicals that God gave us and put it on the planet. I'm a firm believer in the balance of nature. For every problem, there's an answer somewhere in nature. I mean, everything we do. So with cannabis being as ubiquitous as it is in nature, it has to be here for a good reason. I'm not trying to sound like some zealot, who's like, everybody has to smoke weed just to feel happy. But it has been around since the beginning of time, and it is safe again. I'm going to keep kind of pointing that home. So what's in cannabis? Cannabis is the term we use, not marijuana. Marijuana is more of a legal term, kind of like narcotics versus opiates, okay? So cannabis is terms that we use when we're discussing this plant. And so cannabis is going to obviously be cannabinoids and non-cannabinoids. Everyone heard of THC and CBD. Those are the two ones that everyone talks about all the time. THC, because of its psychoactive effect, CBD because of its analgesic effect and anti-anxiolytic effect. However, there's over 100 other cannabinoids, minor cannabinoids, some of which have been studied, some of which have not been studied, and there are almost 400 different chemical compounds in most cannabis plants. And each cannabis plant is going to be different than each. What's going to have what's called a chemovar or strain. So it's like when you go to the produce store and you see kale. Some people like kale, some people like another type of lettuce, whatever it is. So cannabis is a very diverse, it's over 1,000 different strains. But these strains, which are going to create separate profiles, is where the magic is going to be with regards to using it for medicinal purposes. So there's over 100 different cannabinoids. There are over 100 different terpenes. I think it's like 480 different moieties have been seen within the cannabis plant. So the important thing is that cannabis is going to be involved in what's called the endocannabinoid system. The endocannabinoid system, just like opiates and everything else, there's going to be endogenous ligands and then there's exogenous ligands. But the endocannabinoid system is involved in homeostasis in our bodies. Anything that's involved in relaxation, appetite, sleep, extinguishing bad memories, as we'll talk about PTSD later, and protection. It maintains homeostasis. So where do we find these receptors and ligands? We find them in almost all systems of the body, including neurodevelopment, immune function, cardiovascular function, inflammation, as I said, appetite, digestion, metabolism, bone development, synaptic plasticity and learning, sleep cycles, memory. The endocannabinoid system is the most ubiquitous system in humans. Unfortunately, it was not something that's been discussed in medical school. I don't know why it's never discussed in medical school. I guess it's because we're in a prohibition country. But the endocannabinoid system is our most ubiquitous signaling system in our bodies. So the two endocannabinoids, as opposed to phytocannabinoids, are anandamide and 2-AG. I can't really pronounce that word very well. Anandamide is Egyptian for bliss. It's created on demand. And we'll talk a little bit more about where it comes about. It's in the presynaptic receptors, but they are important in signaling, maintaining homeostasis and keeping nerves from overexciting. The 2-AG was recently found, but it's actually primarily found in the brain and is significantly more potent than anandamide. So we all heard about, and I'm sure you guys have all heard about this CB1, CB2 receptors. CB1 receptors are found in the central nervous system. CB2 receptors are found outside the central nervous system. There are CB1 receptors in the gut as well, but CB1 receptors basically are what's important for signaling within the central nervous system. CB1 receptors are what transduce the psychological effects of cannabis. CB2 receptors have no psychological input because they're not in the central nervous system. We know that the CB1 receptors are important in modulating pain, movement, emotion, and as I said, it's in the gut, emesis and seizure threshold, but CB2 receptors are important in inflammation and immune function. There are now 3 cannabinoid receptors. It hasn't been really named CB3 yet. It's a GPR55, but it is broadly expressed primarily in all the areas of pain, the thalamus, the hypothalamus, the nucleus accumbens, the caudate nucleus, the frontal cortex, striatum, and the cerebellum. It's also expressed in the jejunum, ilium, and the mesenteric plexus. So there really are, you're going to hear about it's going to be a third cannabinoid receptor that's going to be very important. So I'm going to spend a little time on this next slide, which is actually, I know it's a real busy slide, but kind of gives you the basic mechanism of how cannabis and how the cannabinoids work and how endocannabinoid system functions. I don't have a pointer, or do I? Yes. Oh, I do. All right. Cannabinoid receptors are presynaptic receptors, and the reason that's important, they function to modulate neurotransmitter release. The location of these receptors overlaps in areas where pain is most important. That's why you see it in areas like the amygdala, the dorsal root ganglion, peripheral nerves, and the nociceptions. There are also CB2 receptors, which are also going to be in the peripheral areas, which are around the glia, immune function cells, the anti-nocis. There's going to be around all the anti-inflammatory mediators, the dorsal horn, and you're going to see this overlap in the components of pain because you have the nociceptive aspect where you can see them in the nociceptors, the peripheral nerves, the neuropathic aspect where you're going to see it with regards to central sensitization in the central nervous system, and in the inflammatory aspect where you're going to see it with regards to decrease in inflammation. So that's why cannabis and the endocannabinoid system play such an important role in the modulation of pain. We can go into greater detail of this, but you'll fall asleep. I promise you, you will. No one really, outside of medical students cares that much about that. So we're going to switch to the major cannabinoids. Everyone has heard of CBD and THC. The reason I have an A behind that is because in their natural state, they exist as an acid. You can eat a cannabis plant and nothing will happen. It has to be decarboxylated from its acid form to its non-acid form in order for it, removing the A, in order for it to be biologically active. So that's both for CBD and THC. All right. So almost all of the, well, all cannabinoids, endocannabinoids, and phytocannabinoids are metabolized through the hepatic cytochrome oxidase system and eliminated through the feces. Okay. The reason that becomes important is that you can you smoke cannabis, but when you have edibles, it goes through first pass metabolism. And if everyone probably heard, the majority of people that show up in the emergency room are usually as a result of edibles. Okay, you pretty much don't show up, other than paranoia, you really won't have a real problem with smoking. But when people overdose on edibles, they show up in the emergency room. And the reason that is because the primary metabolite of THC is going to be 11-hydroxy-THC. And like hydrocodone, the metabolite, which really is analogous to Dilaudid, is much more potent than the original. So the 11-hydroxy-THC is 4 to 5 times more potent than the actual THC. So what happens, obviously, the patient or the person takes their edible 20 or 30 minutes later, and whether or not they've had a fat-laden meal or eaten some mangoes or had a combination of other things, it kind of kicks in and kind of builds up, and everyone panics. But basically, again, no one's ever died from it. So all they do when they get them to the emergency room, sit them in a quiet room and shut them up, pretty much. I mean, every blue moon they might have to give them a little Valium because they're so paranoid they're freaking out and everything. But there's no antidote to it. You just wait it out, okay? So now, again, back to the metabolism of it, and this is going to become more important down the line when we talk about some of the delta-8s and some of the synthetic cannabinoids. Basically, all THC and CBD look very much alike. As you can see, you can barely tell the difference between the two. It's just a hydrogen bond here or there. And basically, we're going to talk a little later about one of the terpenes called myrcene. It has an entourage effect, but then it metabolizes the THC 11, as we discussed, and then it's eliminated through the feces and the urine. CBD goes a similar pathway out through the feces and the urine. But the most important thing to notice here is the similarity between these molecules, okay? This similarity between all these molecules is what the unregulated market is taking full advantage of. All right, and this metabolism has a lot of effects on most drug interactions, particularly with edibles again. As we discussed, because it's going through the cytochrome oxidase system, you can expect an effect, increase in blood levels of antiarrhythmic drugs. You have to watch your warfarin, increases blood levels of statins, the NSAIDs, and you can expect additional effect with caffeine and theophylline. So this comes up mainly with our chronic users, or people who keep some cannabinoids in their system all the time. That's apparently the people who wake up in the morning, the first thing they do is have to smoke something or eat something. I guess it's the new world that we're living in. But so these are the things you're going to have to worry about. It's possible also that this is going to come up with our elderly patients, because I'll tell you, the average age of people who show up in dispensaries is about 65. Okay, you would think that it's going to be a whole bunch of young kids running in and stuff like that, but it's all the leftover baby boomers and 60s people that are right back at the dispensaries. Okay, so let's talk a little bit about cannabis pharmacokinetics. Okay, you can ingest or consume cannabis in multiple ways. Most common is smoking or vaping. The advantage of that is quick onset. Lasts about 3 to 15 minutes in duration. It can last within 3 to 15 minutes onset and about 3 to 4 hours of duration. Relatively low bioavailability, but you make up for that by smoking more. Oral ingestion, edibles, is in most regulated markets is becoming one of the most common ways of doing so. The reason that's important is, and the reason people are moving towards edibles, is because it has a duration of about 8 to 12 hours. The issue with edibles is that peak onset is typically 30 minutes to some people 2 to 4 hours. Okay, and again, as I was saying earlier, that's an issue with regards to overdosing on edibles because people take the cookie 30 minutes later, nothing, and then they take another cookie 30 minutes later, nothing. And it's like, oh, this is nothing. I'll take another cookie, and then they're stuck in a corner in the back and somebody's talking them down. That's pretty, it's very common. It's very common. I'll go back and forth every now and then. I'll try to stay focused. I have a little bit of ADD, so I'll bounce around, so excuse me. But cannabis toxicity, for lack of a better word, always has a biphasic effect, okay? Whatever you're basically treating for cannabis, you take too much of it, it makes it worse. Example being nausea. If people take it for nausea, you take too much, you can get hyperemesis syndrome. Easier description, people who take for anxiety, take too much, they become paranoid. Okay, so it's a biphasic effect. But it won't kill you. Remember that, it won't kill you. All right, and in between oral and inhalational is submucosal or sublingual. Advantage to that is you get relatively rapid absorption, and you miss the first pass metabolism of it. So that makes it one of the more easy ways to do it. But these are all in regulated markets. Now, the problem that we're having now is all of these synthesized minor cannabinoids. North Carolina will be a classic example. Tennessee is a classic example. You can go anywhere in North Carolina now and buy hemp-compliant Delta-8 blank this, or Delta-9 blank this, or HHC blank this, or CBG blank this, and all of this kind of stuff. That's because these are unregulated markets, and because of the hemp law, they have been able to skirt the rules of deriving it from a plant that has less than 3% THC. However, unfortunately, this is really, really not the case because these are not extracted products. These are all synthesized products, and we'll talk about it a little bit more. But in synthesized products in an unregulated environment, it costs more money to do it correctly. So you can imagine what's going to happen. Okay, if you're in an unregulated environment and no one's checking, and it costs you more and it decreases your profit and you don't get any advantage because no one cares, what are you going to do? Okay, so if you could buy it at a gas station on the side, it can't be good. Back in the day, we used to be concerned about spice and all of those things that kids were taking and stuff. Well, all of those spices and K-spice and things, those all are synthetic cannabinoids. And now they're just back and they're calling them something else. Okay, so the big minor cannabinoids that occur naturally are CBG, CBC, CBN, THCV, Delta-8, and Delta-10. Delta-8 and Delta-10 are obviously isomers of Delta-9, but they actually appear naturally in the plant at very, very minute amounts. So if God put it in there at a minute amount, why would we then extract it and give you only that amount? Okay, in a high dose. So that's just my thinking on it. There's no one studying these things, but if Delta-8 is only at 0.01% normally, and now we're smoking only Delta-8, that doesn't sound right to me. So that's my point on that, and we're going to talk a little more about that too. All right, so the mother of all cannabinoids, just to kind of let you know, this is how easy it is to make all these different minor cannabinoids. The mother of all cannabinoids is CBG. That's what's naturally seen in the plant. It doesn't live in the plant very long because the plant takes it and makes it into everything else in the plant. Okay, so you would never see a bunch of CBG in any cannabinoid, in any cannabis plant, because the plant is taking that CBG and turning it into THC and CBD. And it's really not a very difficult transition to, it's not a very difficult transition to change it after the THC synthase or CBD synthase to this versus that. You can see that these are very, very, very similar molecules, okay? But as we know, these similar molecules have separate, very different effects. So CBG has very specific effects. It has actually a very low affinity for CB1 and CB2 receptors, but it inhibits AEE uptake, which is one of those, we were talking about the endogenous ligands that are endogenous cannabinoids. It inhibits its uptake, so you have more of it around. It's also a very potent serotonergic antagonist, but it's a potent adrenergic agonist, okay? So it's very unpredictable if you take it. Now, normally, it would be in such tiny, minute amounts that it really wouldn't have very much effect. But when you're looking at in these prohibition states, when you see something advertised with CBG in it, you're taking a lot of something that you would barely get a little bit of in part of their entourage effect, and we have to be concerned about these adrenergic agonists and serotonergic antagonism. So CBC, cannabichromene, again, another minor cannabinoid, but being sold now in non-prohibition states in larger amounts, and people is known to have anti-inflammatory effects and is anti-nociceptive, but again, very little antagonism to CB1, CB2 receptors, but other TRP channels, which also tell us that there are multiple, we think there are going to be maybe just like the mu, it used to be on the mu1, mu2, and now there are like 8 mu receptors and stuff. They're going to be like 8 to 10 cannabinoid receptors as we start to do more research in it. The United States is way behind in research because we're a prohibition state. There are other countries. Israel has done quite a bit more research with regards to this. That's why we're so far behind on this. So CBN, they call that the sleepy cannabinoid. Basically, it's one of the few ones that does occur naturally. What happens is old cannabis sitting around naturally degrades through oxidation and over time to CBN. That's why people who have smoked a lot of cannabis, if they find some old cannabis that's been sitting around somewhere, it makes them real sleepy. Okay, so that's, they just call it, but it has been marketed as a sleep aid. So now, going to kind of go briefly through the pharmacologic effects of cannabis. It is kind of important because, all right, so remember, it all starts as an A, but then through decarboxylation, at least to 105 degrees Celsius. So THC becomes THC, I mean THCA becomes THC. It activates the CB1 receptor. Remember, we talked about where the CB1 receptors are. They're in the central nervous system, and they overlap in the areas where pain and nociception are around. It's very important. It's used as the benefit of anti-nociception, sedation, muscle relaxation, appetite improvement. We know that. Cognitive dysfunction, and there are some psychological aspects of it. CBD. Actually, CBD, we still don't know exactly what receptors CBD responds to. It doesn't respond to the CB1, we know for sure, and it doesn't have much activity at the CB2 receptors, but it's been shown to be anti-convulsive, antipsychotic, neuroprotective. They use a lot of patients were getting CBD for anti-convulsion, but they found that it really didn't work by itself. You still had to have THC because obviously it has something has across the blood-brain barrier in order for it to have the benefit that it would expect to have anti-seizure benefit. Remember, we talked a little bit about CBG. That's the one that's a little unpredictable because it's a positive adrenergic receptor, but it also blocks lipooxygenase and 5-HT. It's known to be anti-inflammatory. It's anti-nociception, antipsychotic, and it's apparently good for depression. There's CBC. We talked about that a little bit earlier. It's a COX-2 inhibitor, and it's also anti-inflammatory. And the CBN is anti-inflammatory with some anti-convulsive effects. There's a lot of conflicting research on delta-9 THCV, okay? The reason I bring all these up, you're going to particularly states like North Carolina, Tennessee, and prohibition states, you go to these CBD stores or these vape stores, they have tons of this stuff being marketed. And we're going to show you some of the analysis of some of those products a little later in this talk. But it supposedly has the benefits of decreased appetite or increased satiety, which really, very few people smoke cannabis and don't want to eat afterwards. But it says it supposedly decreases appetite. Research is a little bizarre on this one. And it uprates energy metabolism. I'll be honest with you, the research is all over the place on TED. Now, more to the subject that we're more concerned about. So delta THC, one of the physicians just told me that one of his patients is benefiting from delta 8. Delta 8, your body doesn't know the difference between delta 8 and delta 9 if it appears naturally. The problem is, it's not natural, okay? What we're seeing in this giant craze of delta 8 and all these products is a completely wild west of unregulated product. Okay, no one knows where these things are being manufactured. There's no certificate of analysis because no one checks, because it's completely unregulated. If done correctly, these are great products, but there's no way to know that they've been done correctly. In fact, just an example, if this was a naturally occurring delta 8 comes in such small, minute amounts per kilogram, it would cost you $500 million per kilo to extract delta 8 naturally. So none of it is natural, okay? So that's just letting you know. So this is the same people that you will see something sitting on the edge of the, when you go to the gas stations, they are selling these pills that do all this stuff. This is the same people. So as far as I'm concerned, and I would make the recommendation, don't. Okay, just don't take it, because, and now we're going to show you a little bit more. So this is just talking about how it's made. Cannabidiol, you just add some acid, a little solvent and heat, and cannabidiol, CBD, which they can get a ton of, because there's a glut in the CBD market from the hemp market stuff. Can just throw a little acid in it, you get delta 8. But at the same time, that same acid also gives you some delta 9 and some delta 10. The problem with that is, so this is a liquid chromatography graph. You know about the spectrograph. So each one of these little lines is a different substance, and the taller the line, the more of it is in it. You know about that. So they took just randomly about 40 or 50 products off the market in different states and stuff. So this is the Delta Factory Hemp Rainbow 30 milligram gummy 10 pack, which you can buy right here in North Carolina, okay? So this is a reference chromatograph. This is off the chain. This is the delta 8 that they're showing here, but the problem is, the reason it looks so big is these things that they don't even know what they are, and they summate up to make this look much larger. These are substances that they actually just don't normally appear in nature, so there's no reference for it, so we don't know what that is, but it's a lot of it. That we have no idea what that is, and people are taking this on a daily basis. Now, most of these are young people, so they're surviving it. Okay, but older folks, not so much. This is a distillate from a liquid of a delta 8 distillate, where you put it on your tongue. We have no idea what this is. I mean, seriously, they don't know what these things are, and people are taking this. This is another THC vape. Looks really well packaged. It looks like something that you would think is safe and everything like that. Again, we actually don't know what this is. I mean, it's never been identified in nature. So people are smoking this stuff, okay? So again, the take-home point is just don't do it. And this one is called, it's called HHC. Again, unidentifiable chemical, someone's making in a chemistry lab this stuff and pouring it into these edibles, and who knows what the effect is going to be. So this is a label accuracy. This was done by the Journal of Cannabis in 2019. Even products include, this is against Epidiolex, which is the only legal product of CBD like that. But it showed that, this would be in the reference, the majority of these products had way more CBD than they claimed to have in it. Some had so little in it that it really couldn't even be called CBD. And some of them had high levels of THC in them. And so these people, you know, you're going to hear about people, and you've heard about people who tested positive for THC, and they would I was taking CBD, I didn't know what's going on. That's because these products are unregulated, and the market is just throwing all of this stuff out there. All right, so let's get a little bit into the weeds, as they say. All right. Yeah. All right, so traditionally, and you just have to know this language because you're going to be talking with your patients. Your patients probably already know this more than you do, and a lot of you in the room probably know it better than you want to admit. All right, so basically there are profiles of cannabis. Everyone talks about sativa versus indica, okay? Basically, morphologically, sativa plants are the cute little skinny plant. Indica plants have real fat leaves and stuff. Sativa plants grow real tall and skinny. Indica plants fat and stubby. Sativa plants are supposed to be energetic and add euphoria and make you imaginative. Indica plants are supposed to make you sleepy and chilled, and what they call it, in the couch. Okay, so that's basically the kind of generalized concept that people use when they go to a store. But there are no pure sativas, there are no pure indicas. These have been inbred so many times, so long, to the majority of stuff you're going to see is going to be what's called a hybrid. Okay, it's going to be a hybrid strain. So the problem that we have as physicians when we're trying to recommend, because we don't prescribe cannabis, when we're trying to recommend cannabis for certain conditions, is what is cannabis? I mean, apples to apples. I mean, it needs a labeling and a classification system so we can know that people are getting what we're asked. All cannabis is not the same. Okay, so the new classification system is type 1, type 2, and type 3. Okay, type 1 is going to be in the recreational markets. Basically, they're going to have cannabis that has the most THC that you can get per puff, basically. Type 2 is where the magic is. That's the medical market, okay? It's going to have a mixed profile of both CBD and THC, typically CBD dominant, okay? And just enough THC to activate the CBD. And type 3 is going to be all CBD with no THC whatsoever. There's a type 4 and type 5, and type 4 and 5 are, I think 5 has nothing in it. They just use it for roughage or something like that. I'm not sure what they do. All right. So why does it smell like it does? Okay, I mean, everyone's like, ew, you know, it's, you know, and as far as our society goes, with regards to smoking cannabis in states that have legalized it, people have to realize smoking is still bad. Okay, smoking is going to be bad whether or not you're smoking cannabis, tobacco, or anything. No one wants to be around someone smoking. Okay, so we've forgotten that smoking is bad. I mean, anytime you burn something and smoke it into your lungs, it's going to be a bad thing. Okay, but why does weed smell the way it does? Well, the weed smells the way it does because of these things we call terpenes. Okay, when you go out into the forest and you go, oh, it smells so good out here, and you smell the pine, and it seems to liven you up and freshen you up and stuff. Well, that's alpha pinene that you're smelling, okay? Again, God gave us all these things to balance nature. Mammals respond to terpenes, okay? You know, we know when it's spring, we know when it's time to mate and all this stuff based on terpenes and stuff. So some of the terpenes that we're going to be talking about, and I'm going to just talk about the big ones. Now, it's over 100 different terpenes, but myrcene is one of the biggest ones in cannabis. Where's the other one? Beta-caryophyllene is also one of the biggest ones in cannabis. Limonene, which sounds and smells exactly like it is. But beta-caryophyllene and myrcene are the big two, which are what gives that skunky smell, or what the young people call loud. You know, I don't know if you'll have any young people in your history. There's, you know, if you notice some of the cannabis that you smell, it's just so potently, just, they call it loud because you can't help but hear it, okay? But, and some people apparently like the loud because it has such high terpene profiles and stuff like that. As another general rule, as I wax poetic, when you are choosing, if you choosing cannabis as a use, you can almost tell which cannabis will be beneficial for you by the smell. If the human beings who's smelling it decide if they like the smell of it, they'll like the cannabis. Okay, I don't know why, but that's our way of knowing that. I guess it's, you know, very similar to, you know, when you alcohol, you smell scotch, it smells good. You smell something else, it smells terrible. You're not gonna like it. So. The biggest terpene, I apologize for spinning off. The biggest terpene by weight is going to be beta-myrcene. Beta-myrcene, my Jamaican friends will all tell you, if you eat a mango when you smoke your weed, you'll get even higher. All right, that's because it aids in crossing the blood-brain barrier. There's a somewhat synergistic effect with beta-myrcene on the CB1 receptor. It's also commonly found in citrus, mangoes, lemongrass. Again, beta-myrcene by itself, when you're doing aromatherapy or whatever it is, has an anti-anxiety effect and an antidepressant effect, as well as some other effects. Again, it potentiates the intrinsic antinociceptive properties of cannabinoids by lowering the resistance across the blood-brain barrier. It also has an anti-convulsive effect, and has been shown, it's basically, when it's been shown to be bioavailable, unaltered in human plasma within 30 minutes after consumption of a single dose, with peak consumption within 2 to 4 hours. So it's quite bioavailable. And again, it potentiates the effect of THC, and it potentiates the anticonvulsive effect. It has some autonomic effects. They've actually just taken studies where they've had people in aromatherapy, essential oil of 5 minutes improved nerve activity. They did this with EEGs, okay? They had people inhale just a beta-myrcene essential oil, and the other one was almond oil they had as a control, and it definitely showed that there was an increase of theta and alpha brain activity in the posterior brain region, comparable to people undergoing meditation. So beta-myrcene has its own effect by itself. And again, remember, it's one of the most, by weight, one of the most common terpenes in cannabis. Beta-caryophyllene is also one of the most common by weight terpenes in cannabis. And it's got that spicy, peppery smell that you could get in cloves and oregano. It has an analgesic effect, antidepressant effect, anti-inflammatory effect. They claim it shows some benefit in obesity and non-alcoholic fatty liver disease and cardiovascular disease. That research is pretty minimal, so I'm not going to sit here and tell you that's all that's been proven to be the case. Limonene smells and it sounds exactly like it is. Anti-anxiety, antidepressant, anti-inflammatory, gastrointestinal disorder relief, and somewhat protective in the gastrointestinal system. So it's a lot of research. So there's a lot of research out there trying to claim cannabis is anti-cancer, protects against that and the other, but limonene does enhance the anti-tumor effect of certain chemo agents in the treatment of prostate cancer. That's been shown. It does protect against DNA photo damage, and it has some antifungal effects and some protective effects with regards to the lungs. We talked a little bit about alpha-pinene, which is one of the most common terpenes on Earth. It increases alertness, it helps focus, anti-anxiety, gastrointestinal effects, and some memory relief, retention issues. So, kind of breaking it down, if you're going to go with the top 4, and as I remember I said, there's over 70 to 100 other ones. Beta-myrcene being the most common. It's an alpha-adrenergic receptor agonist. It's synergistic with opiates. It increases analgesic, anti-inflammatory effect of both THC and CBD. Alpha-pinene is an anticholinesterase. It inhibits anticholinesterase, which, and this is wrong, decreases the, not cognitive function improvement, it decreases the cognitive dysfunction of THC. So beta-carotene, limonene, when you put those together, beta-carotene to CB2, the serotonergic and increased dopamine, when you add these to it, it decreases the amount of, what's the word I would like to use, goofiness that you get when you get high with regards to THC. All right, so again, this is important because when you start to determine which strain you want to recommend for a certain thing, you clearly want to have things that are higher in these terpenes, and if you want them to get real sleepy and everything, you're going to have them higher in this terpene. So we're going to learn a little bit more about that. So in review, beta-myrcene is what's very important in enhancing the analgesic effect. Pinene is very important in decreasing the cognitive dysfunction. Beta-carotene is very important with regards to anti-inflammatory effect. And limonene is also important in decreasing the anti-anxiety effect of them. And so these are those terpenes that you're going to be looking at when you're making a decision about which cannabis cultivar you're going to use. All right, so when you show up at a legal cannabis store, you're going to see Brad and whatever his name is, and they're going to be all happy. The reason they work there is because they get a discount. All right, no, they're the happiest workers on the planet, you know, and they're going to tell you, and you're going to come in, but here you are, a 65-year-old person who has arthritic pain, and you can't sleep at night, and you're trying to find something that's going to help you sleep so you don't have to take a whole bunch of pills. Okay. Well, Brad and whatever's Chad's name, they don't know anything. Okay. I mean, they really don't. They all they know is recreational cannabis, and they also, you know, what's cheapest, what's you know, because there's a shelf life on this stuff, and they got to get rid of it, and if it lasts too long, so they're going to be selling you that stuff. So, what's needed is a classification system. You just need a way to look at this and understand what you're getting. But instead, what you get is everything's named something. You know, they got Girl Scout cookies, they have Lemon Kush, they have OG this, they have Maui Wowie and all that stuff. And sometimes these things, the names fit what they do, but realistically, they don't. Because that plant, even if you use the same grower for Girl Scout cookies, under different circumstances, different light conditions, different temperature conditions, different things, they're going to have a completely different chemical profile. So what Girl Scout cookies is here is not even going to be the same thing that Girl Scout cookies is on the other part of the country. So these names are useless. Okay, they're really useless. And unfortunately, in non-regulated environments, we don't have any mechanism to label these products so that we can get a consistent product and be able to use it appropriately. Many a patient will tell you, it used to work for me and this doesn't work for me, or that works for me and this doesn't work for me, but they can't get the same thing every time, and so they're unable to really figure out what's going on. Same with regards to, as we talked a little bit about, the dosing. You've got to have a consistency in your dosing in order to be able to get a consistent response. So this is a system that was derived by the Cannabis Cup Award people. And what they have done is, using colors and graphs that anybody can appreciate and understand, you can then look and not care so much about what it's called or what it looks like, but you can then look at these graphs and kind of figure out what's going to work for you. So we talked a little bit about these cannabinoids, remember? So I think that says limonene there, which would be yellow. It looks a little out of focus, but this will tell you the total cannabinoids, CBD versus THC. Okay, so this is going to be a type 2 cannabis. Okay, you're going to see a THC of 12%, a CBD of 8%. Then these minor cannabinoids, which are all less than a percentage, CBC and such. But it's the terpenes that really tell the difference between what type, the aroma and flavor, right? So if you have a high in limonene, you're going to have a real citrusy kind of smell, and it's going to be high, theoretically, in inspiration and energy and calming effect. Much less allowing you to focus, I guess, and much less relaxation. But the important thing is, as you get down here on this end, these are the sedating ones, and these are the energetic ones, okay? So if you have a whole lot of purple and blue down the end, you're going to end up being more of the in-the-couch kind of body high kind of thing. Now, the important thing about that, because when we're talking about pain relief, we know that these things have muscle relaxation and can work in that standpoint. So maybe a person with a chronic pain who can't sleep, they're going to probably want something with more in the blue versus more in the yellow. They also want to know how much THC they have in it. So you really want a labeling system so that the person doesn't care what the name of the product is. They can say, I need something that's type 2 cannabis, CBD, at least 50% CBD, less THC, and I don't want it to make me real sleepy, so decrease the amount of myrcene in it. That's the kind of thing you're going to do. And so this is an example of 3 strains of cannabis. I don't know what the names of these are. But basically, they're going to all have similar effects but different effects. Whereas this one has a high CBD and a relatively lower THC, again, a type 2 cannabis, enough THC to make it count, more CBD, some CBG. Again, remember, these are very small amounts. CBD and CBC are all very tiny amounts. High in limonene, which is going to give you, again, that inspirational side, and you're going to be high in calming, comfort effect, low on focus. This is going to be one that's also a type 2, going to have 11% CBD and 8% THC, 12% THC and 8% CBD. Again, higher this. So these are all going to be very similar, except this one has a little higher THC. And then when you get in the recreational market, okay, again, it's going to be relatively similar down at the bottom, but then they're going to have all of this THC. This has 21% THC, and based on their description, they're going to say that's going to have a higher amount of inspirational effect and, all of that. So the bottom line is you need a way to be able to describe this in apples to apples and not just some goofy description of names. This is another example of something that's going to be more of an indica or more in the couch thing. As you remember, I was saying down in the blue, these are going to make you going to be higher in anti-anxiolytic effect. There's going to be higher in anxiolytic effect, higher in sedative effect. So this one has half and half. It's almost all THC, THCV, I'm not exactly sure why they're putting that in there. And very little CBD. Again, this one is almost 50-50 THC, CBD. This one, again, has got more CBD. This is almost all CBD with very little THC. So you can get this effect, but with less THC. So clearly it's someone who doesn't want to be quote unquote high or hasn't yet developed tolerance, because what happens with this is they start off with lower doses and they develop tolerance just like they do everything else. I see y'all walking around. Am I getting it in? Oh, okay, all right. All right, so again, this is just another example of it. How one would label these so that you can be able to get the same product over and over again. And since we're near the end, I won't go through the rest of these, and we'll be open for discussion. All right. I see you walking. All right. Oh, you don't need these. All right. How do I get out of here? All right. Mm-hmm. Any questions? That hour went by quick.
Yeah. So what does the analysis? You had the analysis done on those plans.
Who does? All right. So in a legal state, there's going to be requirements for testing. Okay. The edibles are going to have to go standard FDA requirements for any kind of food things. So they're going to be what's called certificate of analysis, and they're going to have standards set. The problem is, and even in some of the legal states like in Mississippi, they don't care. They don't do it. So that is still the biggest problem with utilizing cannabis as medicinal. The only advantage is, again, remember, it's safe. So there's some trial and error. People can figure it out over time which one seems to work best with it, and literally which grower, it seems to do a more consistent product, and then people can figure it out. But that's how it's done.
Back here.
Mm-hmm.
So as a young boomer, I would like to thank you for this presentation. This was great. And as a young boomer with a teenager, I would like to know specifically about the beta-myrcene essential oils. How do you know that you have a reliable source for that type of essential oil? Do you have any recommendations?
I don't. I wish I could tell you the reliable sources. I don't. I can't tell you. I wish I could help you with that. Sorry.
Any other questions?
Mm-hmm. Pass the sharing cube.
Sharing cube.
Throw it to him. I think he's behind you.
I have two questions.
I can't hear you.
People
We couldn't hear you, sir. I'm sorry. Speak into the cube, sir.
Two questions. First of all, evidence that cannabis products are beneficial for ADHD. And secondly, what kind of time frame we're talking about the development of tolerance?
So the first question was, could somebody repeat? I'm sorry. Am I on? I couldn't hear it. In ADHD?
ADHD?
Oh.
Is there any benefit?
Oh, that's an interesting one. Okay. Now, this is going to be personal opinion. Some of the areas I've seen the most success in recommending cannabis has been in migraines. I've seen it in people with bipolar disorder. They use those two sativas versus indica when they're up, they indica when they're down, they sativa. And ADHD, Israel has done some work there, particularly in autism, and they've shown some benefit there. I would worry a lot about any cannabis product in a teenager. The reason being that your brain is not fully developed, and the endocannabinoid system is very important with regards to brain development. They've actually, and I don't have the slide here, but they've actually shown, we all knew kids that spent their whole life on the couch, like that. And those kids, they went on to be adults, but they lost potential, as we would say. They actually have shown brain scans that show underdevelopment in certain areas of the brain when teenagers use chronic cannabis. As far as adults with ADHD, I don't have a real specific answer for you there. I would just be my opinion, and I don't think it's worth telling you that if I can't back it up with science.
Yeah.
Okay.
Okay, can you hear me?
I can hear you.
All right. So I work in pediatrics. We have teenagers that get admitted all the time for hyperemesis. Some really sick with acute kidney injury and electrolyte disarray, sodium's in the 1-teens and stuff like that. Is there any thing that you can do about that hyperemesis part, or should they be looking more sativa versus?
No, hyperemesis will go away. It's like opiate-induced, it's like steroid-induced diabetes. It goes away if they stop smoking.
Right.
Okay,
One girl was admitted 20 times in the last 2 years.
That's their parents' problem. No, serious. I mean, it's the advantage to a regulated market. It's harder for teens in California or in regulated markets to get cannabis than it is from unregulated markets. All right, but there is no. That person clearly it's just staying constantly high, and the only treatment for that is just stop. And I don't know what they got to do for somebody to get admitted 20 times with the same problem. But I do recognize the difficulty, and so there's a whole discussion, and we don't have time, but there's a whole discussion on substance use disorder with regards to cannabis. Is cannabis addictive? Okay, some people are using cannabis to treat other substances, use disorders. But yes, cannabis, you can become addicted to cannabis. Almost any substance, some percentage of people are going to get addicted to it. But yes, how one would treat that, I mean, the only thing I would do, again, is just stop it. And if you stop it, it's not like you're going to die from withdrawal. I mean, the only thing you become is kind of a butthole for a while. And I mean, you don't seize, you don't have hypertension, you don't have any of the physiological responses that you have with regards to, yeah, all right.
How concerned should we be with early onset dementia?
Oh, I don't know much about that. That's a good question. You guys are giving me reasons to go look. I don't know the answer to that. I'm sorry.
Thank you.
All right, thank you.
Yeah.
Mhm.